So this is Bandung in Indonesia, which is in West Java. It's a city that has a wider metropolitan area of about 6 million people. There's quite a lot of air pollution issues. It's a beautiful place otherwise, surrounded by volcanoes. And we've been working there since 2008. Reinhard van Krevel from the Netherlands initially established collaboration with the group at the University of Pajajaran, and we joined in a few years later. So the University of Pajajaran was established in 1957. There's 2 campuses, 16 faculties, including medicine, 43,000 students, 2,000 postgrad, 1,300 doctoral. Relatively low proportion, but they have big ambitions to not just send their students to places like ours to train at postgraduate level. We've developed a thing called it's called now the TB HIV research group, but I'm very much only involved in the TB side. And we developed a mission to generate evidence for effective control of TB through high quality research, capacity building, genuine international collaboration, long-term goals and planning, and long-term research careers for Indonesians, and to have societal impact. And the Indonesians are very keen for us to put in to have as much fun as possible while doing so. This is a lake near Bukit Tinggi, Sumatra, where we had a retreat. Just to show you, this is just a selection of the collaborators and 2 inserted people, one of the major Indonesian leaders, Professor Ravina Raslami, and Reinhard van Krevel from the Netherlands. There's a number of different research projects going on. Latent TB infection, which is what I'll talk about this morning. Drug-resistant TB is a major new initiative over the last 3 years. TB diabetes, subject to a major EU-funded project. We've been looking at the private-public mix, the public-private mix, with respect to the fact that half of Indonesian TB cases are picked up by the private system and not notified. TB meningitis has been a long-term interest. And we've started to do work on healthcare workers, especially focused on latent infection, and started looking at some active case finding approaches. So I want to talk about prevention of TB and our fetish or interest in early clearance of Mycobacterium tuberculosis. And then I want to talk about the strategic expansion of latent infection treatment, looking beyond the case contacts to bigger populations of individuals that we might be able to identify, or other populations of individuals might identify for the expansions of latent TB infection before we go to the whole population. And also to talk, so there's 4 groups I'll mention, and then we'll talk just very briefly about capacity and implementation. So I've spent a lot of my career wrestling with phenotypes, I like to call it. And this is a diagram. Down below are all these different characteristics and parameters around different phases of stages of latent infection relationship with the body. And this is just pathogen load. And in green here is the group of people we call exposed but not infected. Then we have latently infected people, and then we have active TB disease. This boundary, what I call phenotypic boundary, is very important, I think, with respect to why we don't get as bigger effect of mass latent treatment along with active case finding as we might think. Probably, I think, because there's a subclinical disease issue going on at this boundary. This boundary here is something that we've become more and more interested in, is the early clearance group and whether we could identify them and distinguish them from those who are not actually really exposed and all that sort of thing, and then work out why they might actually be relevant. So the reason why we are interested in latent infection at a population level in particular is partly related to this diagram that came from Chris Dye's modelling paper in 2008. And the y-axis here is the new TB cases per million in 2050. This axis here is treating latent infection. And you can see if we just treated latent infection alone over a long time period, we'd see a relatively small reduction in TB incidence. If we treated this axis here is treating TB disease, and you can see that just treating TB disease in the absence of latent infection gives you a bigger reduction, but nowhere near what we call the elimination zone here. But if you treat latent infection and a disease in the population at the same time, you get an extra effect. 1 + 1 does not equal 2, it equals more than 2. So you get a big synergistic effect in a population from the modelling anyway. So we used our exposure gradient that we initially developed in West Africa to look at performance characteristics of test for latent TB infection. And we applied the same exposure gradient in Bandung with the quantiferon IGRA test. And this is just simply the proportion who are test positive, whether they're in the same neighbourhood but outside the house of a case, the same house, or the same room within the same house. These are exclusive groups as an index case. And you can see that both the TST and the quantiferon increase steadily at this exposure gradient. And quite a lot of overlap between the confidence intervals, suggesting that there's really not much difference between them. The reason we wanted to use quantiferon was partly because of this early clearance study. So if you can imagine, if you're wanting to do a longitudinal evaluation of latent infection over a short time period, then the confounding effect of the antigens you've inserted underneath the skin from the skin test will be a problem for your short follow-up test. So this is the innate factors in early clearance study that Aisha Viral has done for her PhD. And this is just a schema showing the overall study. So here's your index case here, coughing on case contacts. At least about half of them are actually baseline positive by IGRA test. And then at 14 weeks we repeat the IGRA test, and we follow this. This is our primary analysis, is to follow these initially negatives for whether they convert or stay persistently negative. And we define these as early clearers with some provisos. So in the index case, we gather a whole lot of information, and the contacts also a whole lot of information and some tests. And we have a bioarchive that we build up from the cohort. Their human DNA, their packagings for RNA analysis, the IGRA supernatant is available. We do a whole blood stimulation assay. We've got serum for things like micronutrients. We fix cells at 2 and 14 weeks in a sub-cohort for FACS analysis, and we gather the index case isolate. So all these things can come together in an integrated analysis, hopefully in the overall picture. But I want to show you, after showing you Aisha and some of our colleagues, this is Bakhtiar Pajana and Dr. Alit, who's got a very complicated surname which I have trouble pronouncing, who's also about to start her PhD on some of her work. So this is just briefly to show you the top end and the bottom end of the recruitment. So this is almost 500 households and 2,000 case contacts. And then after eligibility and some small amounts of loss, we ended up with 490 IGRA negative contacts, 780 IGRA positives at baseline. And we follow these longitudinally, and at 14 weeks we had 317 IGRA negatives and 116 converters to compare. This group here, when you take into account losses and all that sort of thing, is about 20 to 25% of the original contacts that are of interest at the baseline. So this is just a table, and I've put the red dots in because obviously with time we want to focus on key results. And this is at baseline. We're comparing IGRA positives and IGRA negatives, and we find that this is just looking over the adjusted prevalence ratios for conversion for a positive test versus a negative test. You can see that the positivity increases with age, as you might expect. And then, consistent with other cross-sectional studies, we find that if you have a BCG scar, you're about 10% less likely to have evidence of infection from an IGRA test. So there's now been some systematic reviews suggesting that this group of people is probably there's about 20% protection overall across studies at a cross-sectional point of view from BCG protecting against the development of an infection as measured by a T cell readout. This is what we found at follow-up, and there's three different things. So at BCG vaccination at follow-up, if we move over to here, this is the adjusted risk ratio for BCG in relation to conversion of an IGRA test from negative to positive. And you can see that we're picking up 45% protection against new infection when we do a longitudinal analysis. And you don't see this on skin test studies for reasons which I explained before. In terms of risk factors for positive risk factors for developing a positive IGRA, smoking history, being a current smoker is a small risk factor, and diabetes, being a diabetic, also places you at risk of developing new infection. So this actually twigged a little thing in my memory that back in 2007 when we published a PLOS Medicine paper on longitudinal evaluation of the AliSpot test, which is a sister test to the quantiferon test, that we picked up this is the 3-month results, this is BCG present here, we picked up an odds ratio of 0.5, which is suggesting almost exactly the same protection longitudinally against the development of an infection. But the problem we had there, and why we didn't make much of a thing about it, was we had a 0.06. So I was thinking of taking some sandpaper to that p-value. Anyway, this is just a couple of, when we start to look at, okay, so we've got BCG doing this remarkable thing around protecting people from getting infected. We think it's real. It's the strongest associated risk factor. And there's some limitations that could suggest things we could improve that could help people improve on the BCG vaccine. And the first one is age. So these are the top table here is the 3 age categories, and noting that we didn't recruit under 5s because they were referred for preventive treatment. This is the increasing age. We find that we've got the decreasing prevalence ratio for development of a decreasing protective level with respect to the prevalence ratio, suggesting that at age 30 or so we lose any protective effect from BCG. On the other side of the coin, we have to go into this study with the impression that that BCG effect of protection wouldn't last anything like 30 years. But this is what we're seeing, that it does seem to last up to about 30 years, and then there's no evidence of protection after that. There's an issue with taking out and extracting a cohort longitudinally when you do age, because of the effect of age and experience and number of exposures on your results. So we can't easily evaluate the effect of age in relation to the interaction of age and the BCG protection. So here's the other thing that we found. We picked up a borderline significant interaction between BCG and exposure levels. So we had made this exposure score for various reasons, which takes into account the proximity to and hours spent with the case and their smear grade and all that sort of thing. We originally created this because we were worried about people not exposed enough to be to actually develop an Tst Positivity, and I think that's still an issue. But we found that with tertiles of increasing exposure, we found that the level of protection from BCG actually decreased. So it went from like 64% point estimate through to 39%. And we wondered why this might be until we started to realize that maybe if it's a predominantly innate response, it's probably not an all or nothing phenomenon. It's probably able to be overcome depending on maybe being overwhelmed by the dose or by vulnerabilities at a particular time. And I think the results that we have can be really interpreted for the situation of a current exposure and may not reflect the level of protection that you have over the course of your lifespan, because there may be a particularly high exposure that you may have, or a particular vulnerability where your innate systems maybe not as good at protecting. So that's the way we're thinking. We have some other results, just some preliminary results. This is Sysmex results. Just the red dots showing a relationship of conversion with hemoglobin. So as your hemoglobin goes up, this is the graph showing the rate of conversion increases. We don't know why this is. This tailing off here is probably related to small numbers, and you can see the confidence interval increasing. I'm very reluctant to talk too much about immunology, so at least to say that you're not allowed to ask me any questions. They'll tell you everything I know in the slide. So this is the facts results in a consecutively recruited 100 or so contacts, where they had a test, a repeat blood test at 14 weeks for FACS sub-study. And essentially, the interesting thing that we found, this is picking out results that were showing something, was that these monocyte subsets, we were seeing a consistent reduction in monocyte subsets between 2 and 14 weeks, only in the early clearers or persistently negatives, not seen in the converters. And we wonder whether this is actually evidence of a monocyte predominant inflammatory response that's cleared the bug early and it's now returning back to normal. And this is just some results from the MAKE cells suggesting that in converters, over on the right here, there's some evidence of MAKE cell increase between the two time periods. So I want to just talk about the move towards strategically engaging other groups other than case contacts as we look to expand latent TB infection treatment in populations. And as part of the TANDEM study, which is a very complicated study across multiple disciplines in multiple countries, including Indonesia here. We did a study looking at IGRA in diabetes cases and compared them with a historical study with IGRA results in case contacts. It's very difficult to work out the right control for a frequently hospital visiting diabetes case with respect to like a community control. And actually, when we realised we had this comparator group, it became quite obvious that it was quite a good one for reasons which I hope to explain. So the TANDEM objectives were to determine the prevalence of diabetes among TB patients and vice versa, best methods for screening for both diseases, management requirements, glucose control and TB outcome, and a number of other issues around pathways and around enhanced susceptibility of diabetes patients for TB, and then cellular and genetic bases. So this particular sub-study was a cross-sectional study, consecutive TANDEM TB, diabetes recruits, and the control group, as mentioned, was these household contacts where we carefully frequency matched them for age. Patients had a blood taken for HbA1c to confirm their diabetes status, IGRA test and chest x-ray. And those with and without a history were defined in these ways: active TB, probable TB, possible TB, and not TB. And when you're trying to identify the prevalence of latent infection in diabetes using this test, which has its limitations, you want to take out the people who could possibly have TB. We call them not TB free. So these are the guys on the right. And these are the results we're particularly interested in. Relatively low number of indeterminates, and then a positivity of 206 versus 324 negative. We'll come back to that in a minute. The prevalence of TB disease was relatively surprisingly high. Of definite TB and already diagnosed with TB was 3.4%. And a possible TB who we followed as a cohort to see how they turned out, many of whom had a TB history and then not TB for sure, as far as we could tell. I won't go into that slide. So this is the results of the matched comparison with case contacts. So we had 140 in each group, and we restricted the age to 25 to 54, and then had frequency matching within the age bands. And we found that the IGRA positivity among those who were TB-free in both groups was 38.6% in the DM group, and almost 69% in the contacts. And the active TB comparison was higher in the DM group than in the contacts. And the history of TB comparison with wide confidence intervals was also similar between the two groups, which made us realise, when you think about it, that the LTBI prevalence being lower and the TB prevalence and being higher makes diabetes patients potentially a much better group even in contacts for preventive treatment. So we took that toward designing a preventive treatment trial to work out what the level of efficacy is, so that planning could, these diabetes patients could be considered for active screening for latent infection and preventive treatment. So we've also become interested in healthcare workers. One of the Indonesian doctors has got a passion for healthcare worker TB and latent infection. And this is a study looking at healthcare workers. And this particular one of her PhD studies is looking at nursing and medical students, noting that their historical increase in risk across studies. And for this study, we've used both the skin test and the IGRA test. Where are we at? With the objectives of looking at their rates of positivity and then looking at their conversion rates. So we enroll medical nursing students before they enter their clinical experience, and then we measure their tests again at 1 year. And then secondary objectives to look at agreement and associated factors with their test results and conversion. So this is a prospective cohort. Inclusion was the students as I described, and there was some exclusion criteria. Baseline testing and for IGRA and TSD, we wanted to also look at boosting. So we've got a subgroup without any TST, and then do 1 year follow-up, look at agreement, have a student logbook to see what their exposures are from their history point of view, and then do our analysis. So we have 461 students in this cohort. It's amazing because you can recruit them all in a week, which is, for a case contact study, people like me, that's remarkable because you're spending half the year recruiting that many case contacts usually. This is the sub-cohort that have TST, 32% positivity, and that group are 21% positivity by IGRA. And this is the whole cohort for, so this is the overall cohort, percent positive by IGRA, and then the negative IGRA, and then retesting, high percentage managed to be captured at 1 year, 8% positive by IGRA, and we just started to look at the TST positivity. This is the overlap between the test results. There's always disturbing overlap between IGRA and TST results. And these are factors associated with the positive IGRA at baseline, suggesting that there's an age issue. And this BCG effect again, this is at baseline cross-sectionally, suggesting quite a strong protection against infection for BCG. And this is at conversion, relatively less power because you have less numbers of converters. Again, medical students seem to be at risk of developing infection over nursing students. We always thought we did more patient contact in reality, didn't we? And then exposure to bronchoscopy, quite disturbingly, is very strongly associated with conversion of an IGRA test. How are we going for time? Looks like I'm just about running out. Okay, so I'm quickly going to talk about a brief feasibility study. We've been looking at the issue of shared social risk factors. So what if we follow patients not just to their homes but to their neighbourhoods, looking at ways to expand in the most efficient way the populations that we would like to treat with preventive treatment. So these are community volunteer women who are amazingly interested in anything to do with health, and they're all over Bandung doing all sorts of things, and we trained them up to take a sputum for smear testing, which was the only tool we had for that study. And essentially, these are three groups. We randomly selected proportional in a cluster sample of the general community. We sampled from TB households consecutively, and then their neighbourhoods of those households. And we didn't pick up any TB cases at all with the smear test for some reason. We didn't expect to pick up a lot, but we found that the whole concept worked really well with these volunteers. But we also picked up from the last 2 years that there were, in these 5,000 general community members, 29 of them had TB case in the last 2 years. One of the household members had been a TB case, and 5 of the neighbourhood members. And if you put a rate around this, with obviously wide confidence intervals, the neighbourhood do seem to have a higher rate of TB than the general community. And this makes us think that that's going to be relevant for latent infection as well. And we're going to take this further with respect to looking at the neighbourhood of TB cases as a high-risk community. I just want to briefly talk about implementation. We've been developing and implementing a public health framework to promote system improvement. Very much encouraged by that very poignant and point of clarity from Paul around the system, not necessarily the tool. And we found that when we were looking at under 5 contacts in Bandung, that when we followed a cohort of 437 of them, only 34 actually turned up to the clinic for assessment for preventive treatment. And then when we followed them out and looked to see if those who didn't turn up were going somewhere else, some of them were, but very few of them. So we developed a health needs assessment tool based on public health framework, and proposed this whole concept of situational analysis, gap analysis, and options analysis by dividing the system into these performance parameters, such as screening compliance, the initiation of isoniazid therapy, the accuracy of disease diagnosis for those who wanted to take out the equation, adherence, and so on, and indicators of performance of the system. This table goes on further. What we think a system should be performing like with respect to the indicator, what's the study, how many people we evaluate for the particular to measure this indicator as a cross-section or a cohort or a qualitative evaluation, the actual performance from that of the system, and then the gap between the indicators of the system and the ideal system, and to give a gap analysis. And then we propose an options process for filling those gaps. And this concept actually was the basis of the proposal to do the Act 4 study, which has been, and it has been improved and modified on since then. And I'd be happy to talk to anybody about it, because I think it works. It's complicated, but it works well, and it is quite comprehensive in a relatively straightforward way that anybody can understand. I wanted to mention capacity building. It's a fundamental component of our relationship with the university in Bandung. There's international masters trained. There's international PhDs. There's current training in PhD. There's now postdoc fellowships. And well over 50 publications over the last few years. And despite this human capacity building, we actually have to slow down quite often to say, okay, we're just going to just hold off before we proceed to another study. So I'd just like to acknowledge all the different people involved in Bandung and other institutions that link up with the group, people at our university and the funders. And at the moment we're looking for new funding, because that's all starting to dry up quite quickly. So we're looking forward to engaging people on new projects. Thank you very much.